So it's about 5 after 10, so we'll get started. My name is Arnold Weinfeld. I'm Associate Director at the Institute for Public Policy and Social Research at Michigan State University. And with our partners at the Institute for Health Policy and our generous funders from the Michigan Health Endowment Fund, we're pleased to bring you this webinar today on COVID-19. Joining me is my partner, Dennis Paradise, who runs the Michigan Health Policy Forum from Michigan State University Institute for Health Policy. And Dennis will be moderating and introducing the speakers. Right now, as you see, we have some Zoom meeting tips. You should be all muted, by the way. And should you have questions, you can either raise your hand in the participant button, or you can put something in the chat box. Dennis and I will be monitoring those fields and can take questions either during a speaker's presentation, after that speaker's presentation, or when we are completed. I believe that that about does it. Dennis, I'm going to turn it over to you. I'm going to put up the agenda. Again, thank you everyone for joining us today.
Arnold, thank you. And thank you all for being with us today. I will introduce our panel of speakers today. And if questions come up during the presentation, we will ask the speaker to answer that question at the end of his or her presentation. And then, of course, at the end of all the presentations, we will do a general question and answer session. Our expert panel today begins with Dr. Deborah Verholden. Dr. Verholden is Associate Dean for Public Health Integration and Director of the Flint Center for Health Equity Solutions. Dr. Verholden is an epidemiologist by training and received her doctorate at Johns Hopkins School of Public Health. The second speaker is Jack Lipton, PhD. Dr. Lipton is Chair and Professor of Translational Neuroscience for the MSU College of Human Medicine. I asked Dr. Lipton what that meant, and he said, translational neuroscience is taking the science from the research bench and moving it into clinical care. So Dr. Lipton earned his PhD in behavioral neuroscience at UCLA. The third speaker we have is Nikki Britton. And I've lost her sheet. So Nikki, I'm going to do this. I'm going to wing this. Nikki is the health officer and for Berrien County Health Department. An epidemiologist by training, head of a local public health department by avocation, I guess. So Nikki brings us an excellent perspective of contact tracing, not only from the academic standpoint, from her epidemiology training, but also from the boots on the ground standpoint as a local public health officer. Our fourth speaker, and this may be new since the agenda went out, is Jonathan Warsh. Jonathan Warsh is the Chief of Staff at the Michigan Department of Health and Human Services and also Director of the Bureau of Care Management and Customer Service for the Medical Services Administration. Jonathan received his doctorate in public health from Oxford University in the United Kingdom. The state of Michigan has just launched, as recently as yesterday, I believe, a contact tracing program, and Jonathan will bring us up to speed on that. Jonathan will be joining the webcast at about 10:30, so we will plug him in later. And last but hardly least, Brian Calley, who is currently president of the Small Business Association of Michigan. But most of us know Brian from his previous career, which was the lieutenant governor of the state of Michigan for 8 years. And as I recall, Brian came from a small business community, came into the legislature as a state representative, then as lieutenant governor, and now has returned to the small business community through the Small Business Association of Michigan. And Brian will be helping us understand what we as a state need to do to transition back to a safe opening of the economy. So, assuming that you didn't all join the webcast to listen to me, let me turn it over to Dr. Deborah Verholden and have her do the introduction for us.
Can you hear me, Dennis?
Yep, I can hear you now, Deborah.
You're going to kill me. I've been doing webinars and Zooms literally nonstop. And my Zoom button is not popping up.
Well, we can hear you. I'm assuming the participants can hear you.
Yeah, I can't figure out how to get back to you guys. I'm super sorry. This has never happened.
Well, it took them 25 minutes to figure out how to get me on board this morning, so.
How about if you do Jack and then I'll go right after him? I'm super sorry.
Okay.
Yeah.
Jack, if that works for you, we'll let you kick it off.
All right, I guess I'll start. So here, let me get my screen up. Hi, everybody. So I'm Jack Lipton. I'm chair of translational neuroscience, as Dennis said. And the reason that I've got into this conversation is because while I'm a neuroscientist and I don't typically deal with infectious disease, our laboratory has developed an experimental test that we're using for research purposes. And I've been part of a national conversation on academic labs being part of the testing strategy. So I'm going to share my screen and start. Let me go to. All right, can everyone see this? Is that a yes?
Yes.
Great, okay. So today I'm going to talk to you about generally about oversight of the testing process, what some of the tests are. I'm going to talk about viral tests and antibody tests, and talk about what those results look like and how they're interpreted so you have a better understanding of what they tell us. I'm going to talk a little bit about the supply and demand for the test in terms of what the stress is on the supply chain for testing. And then tell you a little bit about what we have, some hot off the presses data and some of our solutions for back to work schemes, both at the university and hopefully for employers. So first thing I'm going to do is I'm going to go through the roles of the federal government as it relates to these different things, because you may hear different agencies being talked about, and so I'm just going to go through that as a brief overview. We'll go through viral testing. I'll talk about the differences between people who are positive for viral tests versus people who are infectious. This is a really important thing, and this is developed very recently as it relates to CDC recommendations. I'm going to go through the steps and principles of antibody testing, which is a very popular subject this week as people think about getting people back to work. Supply chain and ways to fix the supply chain through solutions. So first, at Health and Human Services, who does what? This is all new. This was somewhat new to me, and maybe that's because maybe everyone else knows it, but for me, I had to learn this stuff quick as we started to develop our own test. So at the Centers for Disease Control and Prevention, their responsibility is for detecting and responding to new and emerging health threats, which I think we all know. And they're the ones who developed the first FDA-authorized test for detecting SARS-CoV-2, which is the virus, right, that causes COVID-19. The Food and Drug Administration's role when it comes to testing is involved in approving the products and processes for the diagnosis and treatment of COVID-19. They run the emergency use authorization process. So right now, as we're in the middle of this pandemic and people are trying to quickly come up with solutions for testing or for treatment, those have to go through an application process to the FDA called the EUA. And in that way, you're demonstrating your ability to produce a test, demonstrate that you've done some quality controls, and you file that with the Food and Drug Administration. Now, that's an expedited an expedited application, it authorizes the use of a process or technology. It's not actually an approval. So they're letting you do it without really reviewing it and approving the process. And that's what we have to do in an emergency situation. Finally, the Centers for Medicare and Medicaid Services, they're setting the reimbursement rates for COVID-19 testing for Medicare and Medicaid, the biggest payers for the test. And that's at about $100. That's at $100 a sample right now, which is a lot of money. And they interpret and manage the standards for accrediting the laboratories that can run the test. And so those are done through, I'm not going to go into this too much, but it's the Clinical Laboratory Improvement Amendments, and those are the federal rules associated with standards for doing clinical diagnostic testing. And so that's how these three agencies all interplay with each other under HHS. And you have to remember that those labs that are allowed to do that clinical and diagnostic testing as laid out by CMS are the only ones that are allowed to develop new tests and run new tests. So let's talk about tests. So how does viral testing work? Okay, so these are high complexity molecular tests. I know that sounds fancy. It just means that it's not really that plug and play. People are mixing things and it's several steps. And so these are direct tests for the virus, which are different than the antibody test, which is an indirect test of whether you've been exposed. So this will tell us whether you have active virus in your body. And what's the process for that? So we collect a sample, and I'm sure many of you have seen on TV. I know certain news stations really like to show the nasopharyngeal swab and sticking it up people's noses. That is the most popular method for collecting samples for viral testing right now. We have also been using a nasal swab, which doesn't go quite as far into your sinus cavity, just goes up into your nasal passage. And then the saliva kits, which I'm going to talk about a little bit later, are coming online, and they are much better in terms of the stability of the sample and the ease of collection. And there's less errors with the saliva kit than there are with the nasopharyngeal swabs. So we take the sample, then we extract that viral material from the sample, hopefully if it's there, and we see it. And that's pulled out into a solution, and we have a process for that. After that, that genetic material is transcribed. So that's a process of taking the RNA, which is the genetic code of the virus. We turn it into a more stable genetic code, which is DNA. And normally, this in ourselves, this goes the opposite way. DNA is our genetic code, and we produce RNA to make signals. Viruses have RNA, and we're turning it back into DNA to measure. And then after that, we amplify the material, and we see if we can detect it. So if you look at this graph right here, this is several cycles in a machine called a real-time PCR machine. If the sample is there, as we cycle this over about 2 hours, you'll see this bright, this is a level of brightness in a sample. And so it starts to go up through the cycle process, and that'll give us a positive. If we don't have anything, it's going to stay flatlined the whole way across here. You'll have a flat green line. One of the problems that we have with viral testing is false negatives that are related to sensitivity. And so there was a study that came out of Wuhan, China early on, which is the reason that we got into this process, that demonstrated that people that had tested negative after being diagnosed with a positive test, 9 of 14 in the study were actually positive when they were tested with a more sensitive test. So there's problems with this particular test in terms of its sensitivity. It's not perfect, but it's good. All right, so let's talk about this. So the viral test on positive tests versus infectious, and this is something that has come out very recently. This is May 3rd from the CDC, and here's a quote. For persons recovered from COVID-19 illness, the CDC recommends isolation be maintained for 10 days after illness onset and at least 3 days after recovery. This used to be 7 days, and now they're saying 10. But you also have to remember, we've been able to test patients, and we have a study going, and other people have shown this too, that people can test positive for the virus for up to 6 weeks. And this has been causing a lot of confusion for individuals because if you're testing positive, that means you're infectious, right? Not necessarily. So here is an example. This is from this is part of this CDC advisory that came out. They were citing this particular paper. What you do to see if someone is actually infectious, and they've done this in research labs, is test, you take the material from someone and see if you can take that virus that is showing up as positive in your test and see if you can grow it in a laboratory. If you can grow it in a laboratory, that means that the virus is replication competent, means that it can reproduce, right, and it's infectious. If it's not, then it means your body has probably done something in terms of its immune response and inactivated the virus. As you can see here, a 2 would be successfully cultured. This is days post-symptom onset, and you can see here, you can culture it from patients for about 10 days. And you can see here's a line where they can no longer grow these in the laboratory. And so patients after 10 or 11 days, there's no ability for a laboratory to culture their virus, which means that even though they're showing the genetic materials in the test, the person's body is sequestering the virus sufficiently with the immune response that basically cripples the virus, and it's not necessarily spreading. So this is new information we have, that people are infectious for about 10 days. So they've moved it up from 7 to 10, and you can see here, this is the survival potency of the virus, and you can see that it drops down over days. And so these are very tiny, but it goes from 0 to 10 days. And pretty much by 10 days, there's no infectious evidence so far. So that's what we know about viral testing and positive versus infectious. Now we'll talk about antibody testing. This has been the hot thing. Everyone's been talking about antibody tests and how we can use them to get back to work. The antibody test is an indirect test, which allows us to examine the immune response after viral exposure. And so we'll talk a little bit about what that is. So the process for this would be, as opposed to a nasopharyngeal swab or a saliva sample, this would be a blood sample. It can be taken any way, but typically it's done by a finger stick because you don't need very much. You mix it with a solution of buffers, and then you put it onto a cartridge. This is the most popular method that's been around, that has been coming out. And we'll talk a little bit about those flooding the market and some new advisories. And so this mixture gets dropped onto this little port here that has a B on it for blood. And then that material runs up through the cartridge, and much like a pregnancy test that has a band on it, it will produce these bands depending on someone's status. So you can see there's an IgM, there's an IgG, and then there's a C. The C tells you whether the test is working. That's a control line. So if you put the material in and you get that line, then you know you did the test right. The IgG and the IgM are each measures of immunity. You can think of IgM as kind of your short-term immune memory, so that usually appears quickly and it doesn't last as long. And the IgG, which would be giving you your long-term immunity, would be what we'd consider long-term immune memory. There's some problems with these tests right now, and this is why the FDA has changed some of its rules. These tests can have both false positives and false negatives. So let's talk about that. False positives would be the lines appear and you go, oh, I've been exposed to COVID-19 and I'm fine now, right? I'm immune, I'm guessing. But these tests can cross-react with other coronaviruses. So that's what would produce a false positive and give you a false sense of security that you're immune when you're not. We can also get false negatives. There's been dozens of these tests that have been put on the market without even an emergency use authorization through the FDA, because the FDA just kind of gave a green light to let these things out on the market. And I'll give you an example of what this looks like. So we had gotten one of these tests. This came from China through an importer that came into West Michigan. And we ran this test on a patient that we know had the virus. We've been testing him over 5 weeks. He should have shown either an IgM or an IgG line. And you can see here the control line appeared. Neither the IgG or IgM appeared. So this test didn't work, and I would consider this one to be a false negative. So let's talk about supply and demand. And I know this is one of the things you hear about in the news, right? People are, there's not enough testing kits, there's not enough swabs, there's not enough reagents. So you hear all these terms. So I'm going to go through where some of these stress points are. So for viral tests right now, just so you know, there is 48 authorized commercial tests through the EUA process at the FDA. There's an additional 25 laboratory developed tests. These are EUAs that were developed specifically to only be used in one lab. So they're not commercially marketing them. They're just at a lab. So like Mayo Clinic has their own approved test. So 10 of these 25 are at universities. And they're only being used at that one university. The supplies for these tests. So collection tools, you've heard, has been a real problem. There have been critical shortages with respect to nasopharyngeal swabs. People are making 3D printing their own. They're trying to get authorization. And part of the problem is getting authorization and validating this to make sure that these collection tools are doing the same thing that the approved tools do. So this is a real stress point. Extraction reagents, so this is the material that you use to pull the sample off of a nasopharyngeal swab. Those have also been in short supply. And that's why our laboratory has been working on using older technology, which is not kit-based, to try and get around these supply chain issues. And so this is still a problem for these clinical laboratories because they have to run things in a very specific way with very specific approved reagents. FDA has loosened some of the restrictions on these reagents and allowed for research use only reagents to be used, but it's still a problem. Remember when I talked about that step going from RNA to DNA, the transcription reagents are not a problem. The detection reagents, which are the dyes that we use to do the amplification, where I showed you the positive versus what would be a flat line, are still all right. And then there is some danger of shortages with respect to plates, tips, and other things, the things that we use to transfer materials from one place to another in the laboratory, the plates that are used inside the machines. Those are spotty and they can be on a 1 to 2 week back order. So those also produce some bottlenecks for us. With respect to the antibody tests, remember I mentioned March 15th, the FDA allowed multiple unapproved platforms without emergency use authorizations. There's plenty of those, but that doesn't make it good. On May 4th, the FDA has backtracked and is now requiring EUAs, as those tests, some of which are unproven, some of which are just fraudulent junk coming out of China and have been imported, have flooded the market, and they're just not working. The results of this decision, though, may reverberate while these things are still in circulation for a while, even if it's just marketing to consumers. I'm a little concerned about that. But as of May 7th, there are 12 EUAs authorized for these kinds of serology antibody tests, but that doesn't mean that they're necessarily available. So just because they're approved doesn't mean they're out and you can go get them. And remember, these do need a blood sample and they do need to be mixed with a buffer. So it's not something that you just do at home easily, but they are pretty simple. So this is the problem that I see. Both simultaneously, we have not enough tests and we have too many tests. So on April 15th, my colleague and I wrote a Wall Street Journal op-ed saying that there's thousands of academic labs across the country that have the ability to run the molecular test. We actually have our own test, which is 500 times more sensitive than the standard test. We can't get that approved by the FDA, though. We're not a clinical diagnostic lab, so they won't accept that from us. And we were looking for a way to get more laboratories testing because there wasn't enough viral testing going on. At the same time, as I mentioned previously, the FDA has said yes too many times. And so there's an op-ed that came out from Robert Kaplan and Diana Zuckerman in The Hill just a couple of days ago, or yesterday actually, I think, talking about the fact that they've been too permissive when it comes to antibody tests. So understanding what the right decision is when you're in real time trying to make decisions, it's tough. I do think that there's opportunities in here to liberalize the process to allow more laboratories under appropriate supervision to offer more tests like the viral test, but I do think that the quality control needs to be maintained, but they need to develop an expedited review process. So right now, just to give you a little update on what we're doing, this is hot off the presses from last night because I have people working from 5 p.m. to 2 a.m. on sample processing. So we have developed our own spit kit. This is an example of something we're trying to do at the university to develop new back to work strategies that would be cost effective that we can offer not only to MSU, which is the size of a small city, but to employers if we have additional capacity. So saliva kits are a better option than the nasopharyngeal swab. Someone can do it themselves and the sample is perfectly stable when you add in the solution in it for a week or more, so it doesn't have to be put on ice like a nasopharyngeal swab. The standard commercial kits run about $25. We've developed our own kit, which is a 5 or 6 step kit. Costs about $3, and we were in the process of validating it. We had our first hit with a positive patient on our study last night, and so you can see here. I know this looks a little wonky, but these light blue dots here are, this is on our droplet digital PCR system where we can count up the viral load. This is positive for virus, and so that's this little hill here, this molehill. These are basically droplets from the same patient that are negative. These are droplets that are positive, so this would be considered a positive coronavirus test. And so we know that our saliva kit works. In people that are positive, we had previously tested them with a nasopharyngeal swab, and it works now. So our goal is to try and develop opportunities and ways and strategies to get people back to work sooner. So if anyone has any questions, I can answer those. I don't know if those will happen at the end. Here's my contact information. Thanks.
Jack, thank you. That was fascinating. As you can imagine, many questions came in during your presentation, and I'll ask you a few of them now. Okay. Number one, turnaround time, particularly for virus testing. How long, is this a week process? Is this a 1 hour process? Where are we?
It really depends on the laboratory and the region of where people are, right? Sometimes these can take, there have been backlogs of a week to 2 weeks in highly stressed areas. For us, it's a 48-hour turnaround just because we're pulling in samples to run in batches. But I think that it really depends on who's doing it. I think most places we're at about a week. I think Spectrum locally here is at a couple of days now. So it does depend.
This may be more of an epidemiology question, but do you have a sense of how many tests we as Michigan should do in a day to feel that we have some sense of confidence in where we are?
Yeah, my personal view is that we should probably be testing 1 to 2% of the population per day.
Per day, okay.
Per day. I think it needs to be a lot higher if we want to utilize this to, and I'll let my epidemiology and public health people disagree with me if they want to. But I think that comprehensive testing is important. And if we're going to get a handle on this, we need to not be testing the sick. We need to test the asymptomatic. We need to test the people that are reporting to work, because without that, we're only, it's like the drunk under the lamp post who's wandering around, and someone comes around and says, "What are you looking for?" And they're like, "My keys." And like, "Why are you only looking right here?" And like, that's where the light is. If you look in the obvious place, you're never going to find the thing you're looking for.
Okay, and I'll do one more question before we move on. Deborah, I'm assuming that you're geared up and ready to go now. There was a question that came in about what is the most accurate testing method? And I don't know if they were trying to compare virus testing to antibody testing, or so. I'll leave you with the question to sort out an answer.
So there's not a lot of, you won't see a lot of false positives on the viral test. The viral test is looking at the genetic sequence of the virus, which means it's very specific, and you won't get a hit if it's not there. The only time you would get a hit when something's not there is if someone contaminated the sample with virus. So they're very accurate in terms of positives. The negative issue is one of the important things. So when you sample a person, you have to make sure you get enough material. And so one of the things that we examine in the test, there's another number in there, which you don't have to worry about what it's called, what it's for, but it's the RNase-P level, which tells us about how much material that we scraped out of someone's nose. If that number is low, then the viral load and or the viral amount in that particular sample is also going to be low. So if you don't have enough material, you might get a false negative. And so I think that the test is accurate if it's done right. And then, of course, there's newer technologies like the one we're using, which increase that sensitivity. Sometimes those increased sensitivity might be too sensitive because, like I said, there is positive tests, which may not necessarily mean that you're infectious. So it's making sure you understand that that viral load that you're seeing in the sample is one that's more associated with the early phase of the disease when you're infectious versus the clearing out phase of the virus where you're still shedding virus, but you're not necessarily infecting. The antibody test, though, right now, I think there are approved ones that are very accurate. There's only a few that are online right now, and their availability is low because they're early in the production process.
Jack, thank you. That was extremely valuable information. There are several other questions, and we'll try to pick them up during the question and answer session at the end.
Great.
Dr. Verholden, are you operational now and ready to go?
Yes, and now I'm off mute too.
Okay. The floor is yours.
Okay, great. So I'm going to share with you some stats. And Dennis, I took your suggestion and used some of the graphics from Michigan. Because one person and an epidemiologist, I've been really proud to see finally us, kind of mount up and be able to provide, real-time data for folks. As a health disparities researcher, I've been really proud of Michigan, who really jumped out in front to sort of be the first state to say, not only is this what we're seeing by way of cases and deaths. Everybody go on mute. It's really loud. But Michigan was one of the early states to put that data out by race and to disaggregate so we could actually see where the disparities were. So let me give you sort of the big broad sweep of what's happening. And again, these graphics come from Bridge, Michigan, but I'm going to kind of help make sense of some of them. And they're hot off the press. Like I said, most of these data are updated. I know like our county data here gets updated every day by 2. It's based on data that was available as of 10 a.m. So, there really is an opportunity to sort of do kind of real-time monitoring and surveillance. So this is what we look like overall as a state. We've had about, just under 46,000 cases and, close to 4,300 deaths since the start of the pandemic. And, clearly the limitation here with these numbers is this is based upon known numbers of cases and deaths that were confirmable. Likely not just Michigan, but all places these numbers represent an underestimate. But there's no reason to think that any estimates that we would have in Michigan or the extent to which they were underestimates would be different in scale or scope. There's nothing about Michigan that would make our underestimation particularly problematic. The one thing that I want to note here is, and we, you've heard a lot about disparities, and I'm on the disparities task force for the state, and also on we sort of reframed our task force in Flint, and I'll talk about that in a minute. And we're really focusing on inequity. But, what this shows us is there's a lot of geographic variation and the density of cases. And so we all know this sort of big outbreak here kind of started in Detroit. And I was pretty worried. I, as a not quite new Michigander, but, recently moved back, I've been here for 4 years. I said, boy, it didn't take long for not just the virus, but the disparities to make its way down 75 to Flint. And you can see that sort of area down below the Met. We've really just got this really high density of cases per population. And so the point is there is some geographic variability in what we've seen with cases and with deaths. And those areas tend to be poorer and more colored racially, have higher numbers of racial and ethnic minorities. We've heard a lot about this notion of flattening the curve. And so I love these graphics because it really does give us a sense of what that means. These are the total number of cases going back 1 week. There was a point when we looked at this, it was sort of like a, not quite a straight up and down line, but it was very steep. And as you can see, both for the cases and for the deaths, we're starting to see that somewhat level off. And it's a good thing too, because we know that some of what's under the data, and I'll show you another graphic, has a little bit of artificialness underneath of it, because as we increase testing, we are better able to identify cases. And so some of what we're seeing, even with the cases, is a little artificial because we've actually been doing a better job with testing. So where we are right now, if you look at the 7-day moving average for daily cases, this is sort of, again, getting into that world of what it will look like to flatten the curve. In an ideal world, we'd sort of see this 7-day average continue to go down, and then it would kind of flatten out. And so then the question is, well, what is it going to actually take for us to get there, and how do we get there? So we know testing is important, and I almost sort of happy Jack went before me, because, you know, when we think about what is the testing that's going to really help us flatten the curve, it is the viral test. It is people being able to be identified very early, and oftentimes very early means when they're asymptomatic. And so getting people identified early and then being able to intervene, to quarantine and to do the contact tracing and identify other people potentially who've been exposed is sort of the best tool that we have right now to help to get that accomplished. So the great thing about Michigan is we've had a significant increase in the number of tests that we're doing lately. And in the face of the increase in testing, the percentage of positive results that are coming back are also going down. And I'm going to share this. I sort of think it's, you know, it's debatable, and I worry about giving people, you know, black and white answers to things that are a little bit more complicated. But I feel like in these uncertain times, people are really looking for black and white answers. So they've sort of set this benchmark and said that, you know, once states consistently have positive test rates that fall and stay below 12%, that's when, you know, states can start to look at, you know, reopening strategies, because now the prevalence is getting sufficiently low in the population, and the likelihood of people who are spreading, you know, coming in contact with people who are, you know, susceptible, et cetera. But I just worry about us having some magic metric, because, you know, as we've seen from the past, it doesn't take more than about a week. And it's not even a week. The phenomenon tends to happen in just a few days. But within a week, we can literally see a big turn in tides in rates of cases. Similarly, as we've seen the sort of flattening of the curve of cases and a decrease in the number of positive test results and the percentage of positive test results, in the face of an increase in testing, we're also starting to see a decrease in the number of daily deaths. And the one caveat here is, you know, we're sort of doing a better job now of identifying positives. So that yellow line are cases that have been added because they've been confirmed and after review of death records. So just a couple of things I want to point to that I think are important that are happening at the local level. Many of you have heard that the state has this task force. We have two committees right now, one that's focused primarily on testing and one that's focusing mostly on contact tracing. While the state has a lot that's happening in that area, that is going to be such an important thing for us to really take on and get right, especially as we consider reopening and what that looks like. So that, you know, serving in both a local and a state task force, I found it really interesting, because what we've been able to accomplish and stand up in our local task force, and they're now starting to show up all over the state, we can innovate and move at a lot faster rate, I think, than what happens when you are looking for innovation to come from the state and then trickle down to the local counties and to the local jurisdictions. So many of the local counties are standing up task forces. I thought it was really cool. The lieutenant governor, who had a big hand in our state task force, has actually come and visited and participated with our local task forces. And the reason that I think these things are so important is because you have to put these things in context. And I think we've got the good, solid sort of public health strategies, but how those things get operationalized and what they mean. And I'll give you two quick examples of what happened in Flint. And so one thing that happened in Flint is we got this big rollout of drive-through testing. And it was really great, except about 35% of our population don't have cars. And public transportation was stopped almost completely. And then as it started to come back online, it's not that frequent. And you are not allowed to walk through a drive-through testing site. So we got testing, and Genesee County, which is where Flint is we oscillate between the first and the second most disparate county in the state when it comes to race with these COVID-19 outcomes. And if you look at the county health rankings, we are consistently high on those. We are consistently low on those health rankings. So we really need people who are working in the local context, if we're actually going to deal with it at the level that really matters, who can bring that local insight. So we have started now standing up drive-to testing. And I think that's something that we'll start to look at and explore in other places. Unfortunately, we don't have a CVS in the city confines of Flint, but I've been working with them nationally, and they are starting to do and implement drive-to testing in some other places. So the same way they deliver scripts, they are delivering testing kits to people. They're being self-administered and then brought back and being sent out for testing. So these are the kinds of things that I think are more likely to happen and that are already happening at the local level, and in large part through these task forces. What's also happening at the local level, like I said, with that one example, is we're really starting to address the gaps both in testing and in contact tracing. We have a weekly webinar that we started here in Flint, and we had some folks from the state on, and they had this big volunteer opportunity. And so we sort of gave out all this information, and then a lot of people came back and said, I signed up, I got no callback, I got no information. You know, people want to know how to engage. And the biggest thing that, you know, where we really need hands on deck are, you know, this work around contact tracing. And so, again, I think what's happening at the local level is really important, because we've been able to more quickly and more readily get people engaged and get even the volunteer force activated. And then I think the last point that I would make here is that we're really, I feel like this is really the place where we're starting to address many of both the disparities that we see. So kind of looking at and trying to understand where these differences come from, but then kind of looking more upstream at what are the sort of systematic and structural barriers and factors that are in place that have given rise to some of these disparities. And I think a lot of that work is also happening at the local level. So what are sort of the take-home points? I think generally, not in all states, just in Michigan and in many of our counties, things are sort of starting to move in the right direction. And when I say they're moving in the right direction, and it's why I wanted to just sort of say this is what the data are saying, is that it's not just about the cases, right? It's because it's the practices that we're implementing that are helping to do that. So I think Jack's example was really great. If we're only looking where the light is on, you know, there's a lot of different things we could sort of do with data that won't be helpful. So when I say they're starting to move in the right direction, I don't just mean the data. I mean the strategies that we're using, the fact that we have increased testing, the fact that we're not just solely looking where the light is on. I wish we could sort of scale up the kind of work that Jack is doing. And the question was raised, what percentage of the population should we be testing? And I sort of let Jack answer that, but I want to say a little something about that. Again, like, you know, people want answers, they want bottom lines, but I worry because I don't think there's necessarily one magic number. And if there were, there's also some process and good public health that we need to consider in the background. So there are frontline people, there are people who are at a higher risk for exposure, and we should be periodically testing those people. So those people should be being tested every few days, because typically by the time, again, people start to show symptoms, they've already potentially exposed, you know, some unknown but potentially large number of people. So when I say things are moving in the right direction, it's not just about, you know, simply monitoring the number of cases and deaths. It's understanding what we're doing and how what we're doing is impacting what we're seeing by way of the number of cases and deaths. If we take those things away, or if we scale back on those things, then what's predictable is from going in the right direction and the flattening of the curve, we'll start to go in the wrong direction and we'll start to see increases. So I still say it's still a little bit too early to tell, but we're cautiously optimistic. But again, the important point is we can't take away what's working and expect things to continue to get better. So I think the best strategy for us is to continue to practice good public health, i.e. keeping those basic protocols in place. We've got to continue to do the testing. And again, I think the point that Jack makes is well taken. We need to, depending on the question that we want to answer, we need to implement the kind of testing and use the kind of testing that works. If we're actually trying to stop and slow the spread of the virus, we need to be testing for the virus, and we need to be testing people periodically and even before they start to show symptoms. that's my contact information. I know it's the same as the first slide, but I sort of started and ended in the same place.
Deborah, thank you very much. There was a question that you didn't, it wasn't necessarily part of your presentation, but I'm guessing you can handle it. Can you please explain herd immunity?
Yes, I've been talking about this with so many people. I was on a radio show yesterday because the day before I was on a different show and somebody said, well, they're practicing herd immunity in Switzerland. I said, herd immunity isn't a practice. So here's the basics of herd immunity. Consider us the herd. Herd immunity occurs when the likelihood of somebody who's infectious coming in contact with somebody who is susceptible is so low that the herd in general is protected. How do we get to herd immunity? Primarily because people get the disease or get the illness and they develop some kind of immunity, or they are vaccinated and they get immunity vis-a-vis vaccination. So herd immunity is when the herd in general is protected because the majority of people are not susceptible to getting the disease, mostly through immunity or through vaccination. People love numbers. I don't really want to say exactly what that number is. It's typically somewhere on the order of 80 to 90, 95% of the population. It depends really on what disease we're talking about and how contagious it is. But it takes a significant number, a significant proportion of the population to be immune before we can get general immunity for the whole herd.
Thank you,
I don't
Deborah.
think that's where we want. I don't think we want to sit around and wait for that to happen.
Thank you.
Yeah.
I'm going to use the tyranny of the chair to change the order here because we're only going to have Jonathan for another 15 minutes before he has to cut off. So, Nikki, with your permission, I'd like to move Jonathan up a notch, and then you can do the follow-up. He'll have to leave. You can, add whatever review and comment you want. He'll be totally powerless to do anything about it. So, Jonathan, the floor is yours.
Yeah, that's right. And I think Nikki will probably have some good friendly amendments. So I'll defer to her for the local health department expertise. So let me see, Denny, if I can share my screen here. And okay, are folks seeing this?
Yes.
Does that work? Okay, great. So thanks to Denny for having me. And I think, in some ways, I'm sorry, I can't stay longer. I would have preferred Nikki to go first because actually local health is really, in many ways, more important than what the state is doing. And our job really is to support local health departments. They are really the ones that are on the ground doing case investigation and doing contact tracing. And they are really the boots on the ground that are also helping refer people to local communities. So a lot of what I'll talk about today is what the state is doing, but it's really, really hard to divorce what the state is doing from the work that the local health departments are doing. And it's really fundamentally a partnership. So I wanted to start just to contextualize how contact tracing fits into the broader framework that the governor announced yesterday on My Safe Start. And so what you see is, the state is currently in what we're calling the flattening phase and trying to move into the improving phase. And what you see at the very bottom of that, in the gray area, is one of the key factors to move increasingly to an improving, containing, and in those two phases is really a robust contact tracing system. And this is, I think, particularly true as the economy reopens, because today most people have contacts with very few people unless they're working in essential services. So, today we might have a person that has 2-3 contacts. Maybe it's just the people that live in their home. But in a world where there's not a stay-at-home order, the number of contacts per person will rise very significantly as people are in workplaces and engaging in commerce and those kinds of activities. So The overall framework that we use at the state and that public health professionals around the country are using is testing, tracing, and isolation. Isolation perhaps not being the most public facing friendly word, but you know, we want to test broadly. I think what Jack was saying earlier, symptomatic people and asymptomatic people, once we get our testing numbers up, doing really robust tracing, and then both, you know, because we live in this country and not certain more authoritarian countries, we don't force people to quarantine and isolate. We need to support them with the resources that they need, whether those are social supports, food delivery, other community resources. And that is really a role that local health departments are playing. You know, one thing to note here is I think if you look at the countries that have gotten the virus really under control, they have very, very robust tracing platforms. And what that means is both getting information from individuals who have tested positive and tracing their contacts very, very quickly, right? So it's really that the speed at which they are doing so. I think I had read that in Singapore, you know, within 2 hours of individuals getting a test, they have a video call with a public health nurse that is doing a full case investigation, getting their contacts in the same day, contacting those contacts. So the robustness of the technology and the speed at which we are able to do so is really quite critical here. So here's kind of the overall approach that the state is taking. Our goal is, in partnership with local health departments, to contact 90% of confirmed cases and their contacts within 24 hours. 75% of those cases to have a completed investigation within 24 hours, and then at least to start to get contacts from those cases, 50% of those cases. And the reason you'll see that that last number is a little bit lower is that some people, there's sort of a funnel here. Some percentage of people, we're gonna try and call everyone. Some percentage of those people are not gonna pick up the phone. They're not gonna wanna talk to us because, you know, we or the local health department is the government. And then some other percentage of people either won't have the contact information of the people they've come into contact with or won't want to share it with us. And I think Nikki can probably comment. And you'll also see that this is one of the areas where there is variation across the state. So demographically, there are certain populations and subpopulations that are more or less likely to want to give over this kind of information to the government. What you see here is also just, I think, really core to the approach. So local health departments are the lead. And that's important to remember. Our state has probably one of the strongest local health department systems in the country. You know, I think the funding levels, as Nikki will tell you, probably haven't been what they should have been for many, many years. But the strength of those local health departments is really a treasure for the state and something that we want to build on during this outbreak. So what you see is basically kind of two different components of what we're doing here. The local health departments have primary responsibility for case investigations. The state is providing some support to particular jurisdictions that are more strapped. They are leading contact tracing operations. I think I get a lot of questions like, when is the state going to start contact tracing? The state has been, you know, the local health departments have been contact tracing throughout the entirety of this pandemic, right? And it's not a new activity that the state is starting. I think that's a misperception. And then local health departments are also taking the lead on, you know, those local community resources. At the state level, we're providing support in both in the form of state employees that can help with case investigations, as well as a volunteer workforce. So we have an open offer to any local health department. I think, you know, Dr. Verholden had mentioned, you know, there's all these volunteers, and, you know, I think we're fortunate to have received something like 8,000 people sign up. And we don't have a way to instantly send all of those people out anywhere, but we have an open offer to local health departments that, to the extent they want volunteers, and even volunteers from their community that know the community, that we can match them. And then the second thing that we're doing is standing up a centralized contact tracing operation that is opt-in. So local health departments can say, you know, we don't have capacity right now to do contact tracing. Can you take on contact tracing for us? And we actually just launched that yesterday in a couple of pilot counties. It was very successful, new technology system. And so that's going on right now. It's just started. Let me just explain kind of what are some of the challenges with contact tracing. So it's very labor intensive. You have to have people call someone and then follow up. Ideally what we're doing is not just making an initial phone call to say, you've been in contact with someone with COVID-19, but then we call that person every day and say, how are you feeling? What are your symptoms? Do you need resources? Providing that support. As I mentioned, there are also pretty significant disparities. So obviously, areas of Southeast Michigan, the Detroit Local Health Department, Wayne County, larger health departments, Kent County, Ingham, will have larger numbers of cases. And while they do have more staff, the number of their staff doesn't correspond with the exponentially larger number of cases, and so that's a challenge. I mentioned earlier that we expect the number of contacts for folks to have to increase as the economy reopens. You might be going to work, you might be frequenting a restaurant and have had lunch with somebody for an hour and been in close contact with them. And then some of those challenges with reaching people. We might not have the right phone information, they don't pick up the phone, they pick it up, but they don't want to talk to us, or they don't want to give, the information over. There's language barrier issues, hospitalization. So we're really working across all of these different issues. And so that suggests a really comprehensive approach to dealing with these challenges. So here's sort of the core of the state's approach. We're deploying volunteers. Many local health departments have said, I want volunteers that I can integrate into my workflow, and I'll train them and I'll teach them how to use our systems. And that is an open offer. We have thousands of volunteers. They're volunteers, so they can't work full time in many cases. Many of them are furloughed from other healthcare jobs that will hopefully reopen soon. And then we're training, as I mentioned, a sort of centralized workforce. And that will likely be a combination of volunteers and paid staff. And we're working right now to determine what federal funds that have come into the state could be used to pay folks full time. And I think this would be good for communities as a bit of an economic jolt, albeit a small one. But also because having full-time staff, people that are working 40 hours a week, will develop more of the expertise to do this work consistently. And just as an anecdote, Massachusetts is probably one of the states that is furthest ahead. There's a partnership between the state and a health nonprofit in Massachusetts called Partners in Health. And they have attempted to staff about 1,000 folks to do case investigation and contact tracing. Within the first few weeks, they received 32,000 applications for these jobs. Now, not all those folks will be qualified, but within those 32,000, there are community health workers, public health nurses, social workers, people that are really skilled to do this job. The third part is technology. So if you talk to, I'm sure Nikki can probably back me up, this is a very manual process, and many people don't actually want to talk to a human every day and say, yeah, I'm feeling fine, thank you. And so what we're developing right now is a text message based system where instead of calling you every day, we can text you, and that really alleviates some burden for us and for the local health departments. But it also makes it easier on some residents that might say, I don't need to talk to someone. I can text you, one, I'm feeling fine today, or I can fill out a form online. A lot of people prefer to do that. They actually don't want to talk to somebody. I think it's a sort of evolution of the culture. And, many of you will receive a text message from your doctor's office that says, we're confirming your appointment today. And you might prefer that to actually talking to the doctor's office. The fourth element is sort of monitoring performance and providing technical assistance where needed, right? So as I said, I think local health departments are doing extraordinary and heroic work here. And the state is sort of looking and saying, hey, where are we struggling? Where do we need more resources? Where does technology need to support the local health departments? The technology that the state is building centrally to do contact tracing, sort of that automated text, we're hoping to roll out to local health departments. I think, Nikki will probably tell you the systems that we use for this, our disease surveillance systems, are old and they're clunky. And so there hasn't been the kind of investment that's needed to make these easier to use systems in quite some time. And then the last thing I'll say is public communications is really important. So we're working with our comms team to basically get people to answer the phone. And this isn't just mass communications or social media. I think it's real deep community engagement, people that, get a phone call and they don't know who's on the other line. And we're really, really trying to to get people to answer the phone. One thing that we're doing is that the phone call will not come from a random spam number. It'll on caller ID, it will show up as, when it comes from the state, MI COVID help. And so we're going to get out the message that if you get a phone call from MI COVID help, answer the phone. We're going to leave a voicemail. We'll call you back. We understand that some people might panic when they see the number. They may not want to answer. They might be at work. So we're working through all of those very deep logistical details in partnership with the local health departments. So let me stop there. Here's my contact information. I'm happy to answer any questions. I think, all of this work is moving a million miles a minute. But I think that the partnership with local health is really kind of the core of what will make this effort successful.
Jonathan, thank you very much for your presentation and for making time for us today. I know your schedule is crowded. There was one question that came in before your presentation. You addressed it. I think it's probably worth addressing again. Do we have the personnel that we need to do as much contact tracing as we're going to have to do to deal with COVID-19?
So I think we're working to get there. I mean, the challenge is actually not, I get a lot of emails from folks that say, I have 500, medical students, so they can be contact tracers, and I have 1,000 people over here. It's actually not just the people. It is onboarding them, the management infrastructure. Someone has to oversee those people. They're going to have questions. These are, I think one thing that people don't fully understand about contact tracing is that it's not any normal call center job, right? You're going to call people and you're going to say you have to quarantine. And they might say, well, I'm in a home where there's domestic violence. I can't do that. Or they're going to say, but I don't have any food. Or what am I supposed to do with my kids? Or, there's a lot of really complicated social work and public health problems that come up. And so it's not as simple as, just throw people at the problem. And so what we're doing now is trying to ramp in a deliberate way so that we have the supervisory and management infrastructure to manage those people. So I think we'll get there. But, doing this poorly is worse than not doing it. And so we're trying to really do it in a deliberate way that addresses all of those concerns.
Jonathan, again, I thank you. I know you're going to have to sign out early and won't be available for the Q&A session. So again, I'll thank you for your presentation. And do a segue over to Nikki Britton, who can is the perfect person actually to do the follow-up for the boots on the ground perspective. I had dropped my cheat sheet when I was introducing Nikki. And there was one thing that I wanted to mention. Nikki was named as the Kresge Foundation Emerging Leader in Public Health in 2018. So that was a kudo that I wanted to give to Nikki. So Nikki, the floor is yours.
All right, I'm gonna try to get everything shared here. Let's see. Oops, hold on. I did something wrong. Okay, you can see the PowerPoint now?
Yes.
Okay. So there's going to be a bit of overlap, as Jonathan mentioned, as you might expect. But what I'd like to do is, I guess, we've talked a lot about contact tracing. We've heard a lot about contact tracing in the media. Well, let's see if I can get this to advance. But I want to give you more of a basic idea of what exactly contact tracing is from more of that nuts and bolts. So as any epidemiologist would, we're going to represent people with circles and their contacts with lines here. So starting off, you'll have a case that this is somebody who has found access to testing. That experience is widely variable across the state of Michigan. But so every lab or healthcare provider that diagnoses COVID-19 is legally required to report it through the reporting system. This gets to local health departments pretty quickly. So we'll identify that there is somebody who is COVID positive. As Jonathan mentioned, time is of the essence. So we act quickly to interview that COVID-19 patient, and some of what we're sussing out in that investigation is who they've been in close contact with. Now, close contact per CDC guidelines is defined as being within 6 feet of each other for several minutes. The CDC tends to use 10 minutes as a guideline. Sometimes we're a bit more conservative and we're asking people about 5 minutes, but we want to know who's had that close contact. So it's not necessarily somebody you've passed in the hall at work. It's not somebody that you were in the same aisle with at the grocery store, but it's who have you spent time with. And this has to do with the disease transmission. The disease is transmitted person to person. There's certainly surfaces and droplets that remain on surfaces for a while. That does play a role. We're primarily concerned about person to person. So we talk to our COVID positive person. We are able to identify in this instance, this person has had contact with these 2 green people. So our positive case is our index case. And then the people who are represented by these green circles, those would be the primary contacts. So we, as soon as possible, we get a hold of these primary contacts. Now we ask a slightly different set of questions to these contacts compared to the confirmed case, but a lot of what we're trying to assess is, first, are they ill? What symptoms might they be experiencing? We want them to tell us about their contact with the index case. You'd be surprised the amount of times that the story doesn't always jive, or the last day in which people had contact is remembered differently between 2 people. But we ask the primary contacts about when they were exposed, what that was like, and understanding that date of exposure is really important. And I believe Jack referred to this in his presentation, but an exposure doesn't mean you now have a detectable viral load in your body or that you were sick immediately. So it often takes at least 4 or 5 days. It can take longer for these primary contacts to either develop symptoms or even have enough of a viral load that if they're tested without symptoms that it would be detected. So that onset date or that exposure date to the COVID positive is really important. In our county, what we have opted to do to be really robust in our contact tracing is if one of these primary contacts is symptomatic, we go ahead and ask about secondary contacts. So who have the green people been in contact with? And so this represents those secondary contacts. Sometimes now that testing is more available, we are able to send these symptomatic green contacts. They will be sent for testing, and it's possible that they then become a positive case and then they're their own index case, and we track them all the way through. Sometimes that testing isn't possible, depending on sample availability or depending on the risk factors of these primary contacts. There are some counties, especially in rural areas in Michigan, that it is incredibly difficult to seek a test. So a relatively healthy adult who's experiencing symptoms as a primary contact, they may just be marked as a probable case, fit that probable case definition, and will never be tested. In Berrien County, we have relatively more tests than other communities. So it's possible that the cycle kind of continues that way. But so in contact tracing, we would then identify some secondary contacts. We'd ask similar questions of these individuals, all the while making sure that we are providing information about isolation and quarantine, and that people know how they need to keep those around them safe and how they need to really isolate if they're symptomatic. And isolation of symptomatic people from their household contacts, that's extremely complicated. And I know Jonathan was alluding to some of those complexities. We have families in our community where there might be 8 people living in a 2-bedroom household with 1 bathroom. You can't really effectively isolate or follow CDC guidance to try to prevent spread in that household. There's a lot of complexity. And as we're having daily touch points with people who have either been exposed and are not symptomatic, or exposed asymptomatic, or even positive, we're trying to help them work through these things so they can also protect their loved ones. You can continue to follow the chain down to tertiary contacts and then even the quaternary contacts. Generally speaking, if we're able to have enough testing and we're able to get primary and secondary contacts into testing and we're identifying them quickly, it should never get down to this level, because each transmission is going to take, again, 4 or 5 days before, or each generation, I guess, of transmission here. It takes a few days before the virus is amplified enough within the body to become infectious. Some of the things that also add to the complexity of contact tracing and why I firmly believe we really need people that have both or really have the skills to do this, it's both science and art, is we are asking about where you have been and who you have been around for the 48 hours prior to your symptom onset, because that is the period that has been determined to be most infectious, is 48 hours leading up to your symptom onset and then while symptomatic. That can be really challenging even to define the date of onset for some people. You've all, I'm sure, had this experience even when you're starting to come down with influenza or a cold. It's a little murky to decide what day did I really start feeling ill. Not always, but sometimes. So there's a lot of that complexity that our contact tracers, our public health nurses that are doing this work really have to suss out with individuals. So I had borrowed Berrien County's adapted version of this graphic from MDHHS. This is very similar to what Jonathan showed as well. But the whole premise here, again, is, as he mentioned, is we want to test, we want to trace, and we want to isolate so that we know that people who are infected are a major source of exposure and transmission risk for others. So if we can remove them from other people, we can break some of those lines of transmission. I've added this extra arrow here from trace back to test, because in our community, we are able to send the majority of close contacts that we've identified probably within the last week or two is when the supplies have become available. But we are starting to send people through that test so that we can know before somebody goes through their whole 14-day period, whether or not they're positive and what risk. That does help us, again, to Dr. Lipton's point, help us look a little bit beyond where the light is shining. But it's worth noting, we have barely enough resources to look beyond where that light is shining. We really do have to focus our efforts and the bulk of our time and effort on following the symptomatic folks along the way. And again, getting folks into isolation, there's a lot that goes into that, and that is a lot more complex than you might think. There are ways with the public health code that we can legally compel people to be isolated or quarantined if they represent a public health threat and they are not complying with our guidelines. At this point, we've had great cooperation in our community of people staying put, and I think it's because we are doing as good a job as we can of trying to meet their needs, recognizing their hardship. I do think that the isolation and quarantine is going to become increasingly difficult as sectors of the economy are opening up and more employers will be expecting their employees to report for business, or depending on who you are and how many connections you have, you might have multiple quarantine periods. I know there's some federal policy that allows for sick time for quarantine, but there are limits on that, and it's entirely possible you might have to quarantine multiple times if you are not actually infected during that quarantine period. So a lot of complexities. But one thing that is really great is, I guess if you think of it this way, contact tracing really is the bread and butter of public health. This is what we have skills. We investigate communicable disease, infectious diseases all the time. The contact tracing piece of it is not exactly what we do, but it can also, there are parallels in sexually transmitted infection investigations. These are things that we know how to do. We have that skill and that knowledge as local health departments. But the thing that I think is really important in this time of COVID-19 response is contact tracing as an activity kind of naturally puts a health department at the center of the hub of activity of what's going on and gives us a really good vantage point, but also really good touch points with other partners. So with the health department at the center here, we have contact with individuals. So I'll have it on a coming slide, but I mean, we've contacted thousands of individuals in our county in the last 2 months. And this really helps us to build relationships and trust with members of our community. As Dr. Holden was describing, there are a lot of people that don't trust government, don't trust healthcare. There are really good reasons in history why certain populations would not trust government or healthcare. But if we can have some one-on-one relationships with people where we show up and we call them every day like we said we're going to, we meet their needs that they're bringing forward saying, I can't do this or I can't do that, that is really helps us to build that relationship. You build trust when you show up and do what you say you were going to do. This gives us an opportunity to do that thousands of times for thousands of residents. So it is a ton of work, but I think if we look at this as an opportunity for growth and how can we enhance our relationship with our community so that post-pandemic, we have that framework or that enhanced relationship, that's really important. Those conversations also help us just really learn more and continue to hear what's going on the ground. We oftentimes hear of some preventive measures that people thought they should take or didn't think they should take or didn't fully understand. And so we're able to get some accurate information out there that folks are then sharing with other people that they know. And we're able to hear what are the barriers to staying in isolation? What are the barriers to all of those guidelines we keep telling people to do with social distancing or washing your hands? I mean, there are people in our community that we've had to provide soap to because they are living in conditions in which hand soap is not something that is readily available for them, and they don't have funds to purchase it or means to get to the store to make sure they have adequate hand soap. We worked with municipalities before the governor's executive order came out to make sure that everybody had water to wash hands with. Understanding some of those complexities that might not always come to top of mind for people serving in local government is really important. So again, that connection, that relationship is really important. We also are able to closely just monitor the needs and work to have them met. I was hearing from a community leader yesterday just talking about how COVID-19 has really turned what has been a crisis in many low-income communities and communities of color for a long period of time, with a lack of access to resources, worse health outcomes with health inequities. COVID-19 has turned it from a crisis to a catastrophe, the layering on of one more thing. So there are a myriad of needs that have already been unmet. Contact tracing in COVID-19 has given us a little bit of a gate into, or doorway or a window into some communities, and they're really complex needs that we may not have been able to effectively penetrate previously. And this gives us that little bit of an opportunity to know what's going on, meet some of those needs to the extent that we can, and again, build that relationship. And we also have to have a lot of communication with workplaces. There are a lot of people that are working right now, essential workers that are ill. We are doing contact tracing on them when there's other essential workers. This has given us a good dry run of understanding exactly what workplaces need to know, what they already know, what misconceptions they might have, because we are preparing for the gradual reopening of the economy and having different sectors coming back online and more workplaces being open. We are so much better equipped to be able to meet the needs of our local workplaces because we've done the contact tracing and have had those conversations. We have an FAQ document for businesses that we're putting together on the 15 to 20 most common questions we get from employers. So that's situated us very well. And then we've been able to further understand and work to address some of the underlying causes of inequities that have been there, but COVID-19 is really shining a light on. And that's very important for our department and to have as good a public health as we can. And just to give you an idea of that, and I know Deborah Verholden definitely, Dr. Verholden shared these themes with us, and I apologize, the font is kind of tiny here. But you can see on these donut rings, on this left one is the confirmed and probable cases in Berrien County. Now our population is about 155,000 in the county, and about 14% of the population is African American. You can see here that non-Hispanic Blacks represent 36% of our confirmed and probable cases, and they represent 55% of our deaths. There's absolutely a disproportionate burden of COVID-19 at the state level, and it trickles right on down to our local levels. And again, just hitting home what Dr. Verholden was talking about, the need for that local context and understanding of what's going on is really important. Contact tracing is that intel gathering for us, and another way for us to be part of it. It's not the only way we're engaging in trying to address these inequities, and it's a layering on of other health inequity work we've been doing, but it's an incredibly important thing for us to recognize. And then last, just to give you some perspective, Berrien County we had our first positive case on March 21st. So not quite at the beginning, but close to the beginning of when the state started having cases. As of yesterday, we have 354 confirmed cases, which is a little bit more than some of our surrounding counties. If we have another almost 200 probable cases, so those are people that have had contact with these confirmed cases, but were never tested to confirm, but they likely had COVID-19. From those 354 cases, we've identified approximately 3,400 close contacts. That's a lot of people. In the last, probably throughout the month of April, while we had the stay home, stay safe order, we were averaging probably 4 to 5 people that fit that close contact definition that I spoke about. In March, before that order was in place, with some of our first cases, which was really before anybody was super concerned, we had some folks that had 20, 25 different close contacts that we were then following up with. We do expect that number of contacts to grow significantly as people do start heading back to work. And I think we've all observed that something happened over the weekend as we flipped into May and the weather turned a little bit warmer. There are a lot more people that seem to be going a lot more places. I'm not 100% sure where they're going. But we are bringing other sectors of the economy online as well. That's important. People are just moving about more. So we've made, this 9,000 number is probably a gross underestimate of the number of calls, but we've made thousands and thousands and thousands of calls. As Jonathan said, we do check in with people on isolation and quarantine daily. That helps with compliance, but it also helps us recognize what their needs are and how we can meet them. And then our health department, we thought this was another important way to really have inroads with our residents as well as help our local health system. We've actually provided negative test results to the vast majority of people who have been tested through Spectrum Health Lakeland, our local healthcare system. So we were able to contact them, let them know what their test result was. That was in service to our health system partner. We've since stopped that because we've sort of reversed. They were incredibly busy planning for surge. As we're continuing to do all of this, we don't have the capacity as contact tracing has ramped up. But that has given us another opportunity to be with our community and get effective messaging about COVID-19. Because even if your test was positive or negative today, here are all the things you need to know to ensure that or try to prevent transmission in the future. So I'll stop there. Happy to take any questions.
Well, thank you, Nikki. You certainly have made a convincing argument that the boots on the ground approach is way more complex than the organizational structure, and the contact tracing is not an easy thing to do. We aren't going to just be able to take untrained people and throw them into the mix. You stepped on one issue that related to a question that came in before the conference, so I'll ask you to repeat it. Your answer, the question was, is there some mechanism in law to compel people who refuse to comply with best medical advice about isolation if they're COVID-19 positive?
There are ways to invoke the public health code to, essentially detain someone if they represent a public health threat. Usually it's referred to in the law as recalcitrant behavior, and typically this has been reserved for somebody who might be HIV positive and is continuing to engage in really risky behavior and not notifying those that they're engaging in that behavior with. That is a public health threat, and there have been times that unfortunately people have been detained to eliminate that public health threat. So there are things that local health officers can do within their jurisdiction if there's somebody that's really representing a threat. It needs careful consideration as to when and how that is used and against who, because it can set a precedent. And I think every health officer in the state of Michigan would be really, really thoughtful and hesitant to utilize that power without fully thinking through how it would be utilized and wielded throughout the rest of the pandemic.
again, thank you, Nikki. Well, we've had a lot of health perspective about what we need to do. Now we bridge to what we need to do to open up our economy again. What does the business community need? And how can we healthcare, play a constructive role in safely opening up the economy? So I will now turn it over to Brian Callie.
All right, thanks, Dennis. And yeah, as you can see, I'm in my my mobile office. I do these. I do all such presentations in my car because it is the only environment in my life that I can control. I have kids and a puppy at home, and it just doesn't work. And like a lot of you, I'm not considered essential, so I can't go to the office. I'm not even minimum basic operations, so it's just kind of hard to it's tough to cope with that reality. I thought I'd just by way of introduction, before we get to a couple of slides, just lay something out. Business owners right now are having to get comfortable with a lot of practices that they've never had to even think about or contemplate before, and they're going to be important partners in containment of the disease and the spread of the disease. And but there's a lot of work that has to be done as the business owners start to engage in these activities that haven't been a part of their past. As we see the sectors of the economy, actually more accurately, facility types within the economy come online, we'll see how that partnership develops and grows. So for the slides that I wanted to share, it really has more to do with the way that risk mitigation will happen inside of our inside of the workplaces, inside of businesses. And really, these are meant to be overall across the board type of principles that will apply to practically any business. There's always exceptions to the rule. There are some that are going to need more than what I'm talking about here, and there's some that happen in total isolation that maybe would need less. But let's go ahead and just start with the first principle here, and this is health screening. The reason that these slides are set up and the order is set up in the way that it is because there's a system or there's a method to achieving success in preventing disease from spreading within a workforce or among the workforce within a facility. And all of these things that I'm about to talk about, they work in concert. And I've been trying to come up with what's the right illustration for this. And I think really it's like a filter. If you think of it like a filter, and there's levels to the filtration that happens. And the first level is health screening. There is nothing that you can do that is more effective than keeping sick people from entering the premises in the first place. You know, I hear a lot of people talking about personal protective equipment that has an important role to play, but that can never be as effective as success in keeping people who are sick from entering the workplace. But we know that's not perfect. We know that some people are asymptomatic, or there's some period of time when they're contagious, but also asymptomatic, and so that's so this is a real challenge. What we see happening now, though, is let me just give it a little bit of background on it. This is brand new for most employers. There's some in healthcare. When you go into Mott Children's Hospital, I happen to know because I have a daughter who had open heart surgery. I know that every time we go in that building, we go through a fairly informal and a very easy short, but we go through a health screening. The health screening that will be required in the future for all or nearly all employers is going to be much, much more involved than that. The part of it is just asking about symptoms. There are applications and reports being developed where employees, before they enter the premise, can answer certain questions about symptoms. But it's also, we can see from orders coming out of the state, that it's likely to be required that some employers, especially those who have a large workforce congregated together, that the employer is going to have to take the temperature of employees as they enter. And so this is where I think the first important partnership exists. It is my understanding that the systems are being built right now to where that information can be shared. It's not testing for the disease, but it's understanding who has symptoms and where those people are. And in aggregate, my understanding is that there's some great or useful public health work that can come out of just knowledge of understanding where people are having the symptoms on a very, very wide basis, wider than probably testing will reach in the short term. So health screening is that first thing. Keep people from getting sick, or keep people who are sick from entering into the workforce. The next one is distancing. So this is like another layer, another filtration, if you will, that you keep people who are sick from coming onto the premises, step one. Step two is, to the extent that you have people on your premises now, that you keep them apart. And this is more than just setting aside or more than just saying stay 6 feet apart. This is about engineering of processes. So right now, workplaces they engineer their workflow according to what is most efficient for the production of the product. Keeping people 6 feet apart has really never been a goal. And it's not to say that it couldn't happen in many workplaces, but it's just not been a requirement. There's been no incentive to do that. And so part of social distancing inside the workplace, especially in manufacturing environments, will be engineering the social distancing into the process itself. So the second line of defense after health screening is social distancing, separating people in the regular workflow to the extent that you can keep people from coming in contact with each other in any way. In a perfect world, they would have no contact with other people while operating machinery, for example. That's not always possible, and certainly there are lines of work outside of manufacturing where that becomes much more difficult. So the next level of filtration, if you will, is disinfecting and sanitation. Most workplaces are used to janitors coming in every night to clean the facility, and that's the schedule, right? Something gets spilled in the middle of the day, sure, then at that point somebody's gonna take care of that mess. But for the most part, there's a nightly cleaning schedule for facilities. That's a thing of the past. And so the next line of defense would be regularly disinfecting and sanitizing tools and surfaces, and especially surfaces that are touched by multiple people. Again, you're going to try and engineer most of that out of the process, right? You want to go away from tool sharing. You want to go away from people working in within 6 feet from each other, and the handoff of different products or different things. The more that you can keep people from coming into contact, the smaller the role, or the smaller the need or the risk of not sanitizing well enough gets. So, but you still need to be aggressive. You have to assume everybody is carrying some level of risk. And then the final line of defense, if you will, is personal protective equipment. And the reason that I lay this out this way is that I'm quite concerned that many employers are thinking, well, as long as I get face coverings, I'm good. And face coverings should be thought of, while they're essential and they have an important role to play, that their face coverings will be most effective if you get those other 3 steps right, and if you do them robustly. And so the personal protective equipment is really for those cases where it's not possible to socially distance within the process. I haven't had a haircut in a very, very long time, and whenever it happens, and I don't know when it'll happen, I'm going to either join a rock band or get a haircut sooner or later. But the thing is that there are some professions where it's just people haven't figured out how to do it from 6 feet away. And in those types of cases, personal protective equipment become very, very important. But as a kind of belt in most workplaces, hopefully, the use of personal protective equipment is more of a belt and suspenders approach, because you've taken so much of the risk out of the process that, yeah, you're still going to wear face coverings, but for the most part, you've engineered out of your entire workplace much of the risk. In fact, we think and we hope that for especially in these summer months when people are going to be, they're just going to be less compliant. We already see that with the cell phone data and the movement of people. When they go to work, that might actually be the safest place, because that's where that's regulated. There are requirements and there's rules that have to be followed there. One other thing I meant to mention in terms of social distancing is that there are some professions that lend itself well to process adherence and also the use of safety or adherence to safety procedures. There are some professions like office work that, in a perfect world, those in many cases, especially when people actually have offices, as opposed to big open areas where people are packed in, those on paper, they contain less risk. They're set up to where you could easily contain risk with high fidelity. But the culture in office environments is one that I think we'll have to do some work to overcome, because in manufacturing, people are used to following OSHA standards. It's part of their daily life. It's how they're graded. It's how they're regulated, and people are used to following rules. In an office environment, they tend to be much more casual and less structured. And so when you're trying to take this type of structure and put it in a work environment, that's, I think, the cultural transition is going to be more of a challenge than coming up with procedures. Procedures really, frankly, they're not all that complicated to take much of the risk out of the situation, but high fidelity with those procedures could potentially be a challenge. So that's what I had for you. Is we're trying to educate our members about these things. Not all the rules in every industry are out yet, but we're encouraging people to think about risk mitigation on their premises in the terms of those four main filters, if you will, to take the risk out of the situation for your employees and your customers.
Brian, I thank you very much. You'll be interested to know that what I'm reading from the public health standpoint talks about the best way to approach the opening of the economy is with layering of preventive measures. So not just in the workplace, but society overall. Now, the limiting factor there is that relies a lot on personal responsibility, and that's not always a 100% guarantee. But the layering of preventive measures clearly is the pattern forward from a public health perspective. So it sounds like we're talking the same language as the business community. There is a question that came up. I'm not even sure it's fair to ask you, Brian, but I will, because you can't get to me anyway. And the question is, who pays for testing? It is clear that for diagnostic testing, those tests are covered. There's uncertainty about who is responsible for covering the test for screening tests.
Well, when it comes to screening itself, that's of course much different than like the swabs and sticking up
Right.
your nose, running those tests. So I don't anticipate there's going to be any kind of government assistance in setting up the screening processes. I think employers are going to have to do that, and that's it's mainly going to be staff time. I'm a little bit concerned though about the just the idea of health privacy rules, and especially for small employees. It's one thing if an employee takes their own temperature at home and reports, hey, I've got a temperature, I can't come into work today. But if an employee comes into work, they go through a health screening and they get sent back home, then especially in a small environment, maintaining their privacy and adherence to privacy requirements is much more complicated. So there are a lot of details that are going to have to be worked out with respect to health screening.
Hey, Dennis, I have a question if I can.
Please.
So I appreciate, Brian, what you're talking about, especially in the workplace. One of the things I've been reading about, the questions that is coming up about clothing retailers, clothing stores, or even some of the tourist shops, say, up on Mackinac Island and around our state. How do you see those being impacted in terms of, there were some comments by some of the shop owners about being concerned with people touching items, touching clothes, or even trying on clothing?
Yeah, that's going to be a challenge. Now, I don't know all the procedures that a retailer goes through when clothes get tried on now. They get tried on, and you're not supposed to put them on the rack. You're supposed to put them in another area, and I don't know what process they go through at that point. But I think those types of questions they're going to get much more complicated. The idea of keeping people separated from other people is one part, but people separated from product is until they're ready to make that purchasing decision. That's another unanswered question. I think it's one of the reasons why retail and tourism type businesses have not been green lighted as quickly as say manufacturing. A manufacturing environment is one that is it's very controllable. And but when you have the general public, or places of public accommodation, that just puts more factors at play. And it's not that those factors can't be controlled, or those factors can't be mitigated. At least it is more difficult to do. So clothing retailers, that's going to be a little bit more complicated to figure out. But maybe some of the scientists at Michigan State can. Maybe there's an ultraviolet room or something, stuff gets hung in, or that type of technology there's probably going to be a market for it, because I think people are going to want to know who else has put this article of clothing on, or if there's any risk like that.
Good time for entrepreneurs.
Well, I wouldn't say a good time for entrepreneurs. Yeah, it's been a challenging time, but out of it will come some opportunity, and there are some, we can see some businesses will be completely ruined because their entire model is out the window. But then there's others who are going to innovate and come up with things that nobody ever thought about, and they're really going to find opportunity in it. So but I think the intersection of science and business practices is going to reach a whole new level of opportunity.
Brian, a question just came in questioning whether there's any compliance requirements for business to take these steps that you've outlined.
There are. Actually, the framework, the overall philosophy is not one that's new. Even though it's been refined and people know more about it, it's been crafted somewhat around the current threat. The idea of layering in the elimination of risks of all sorts and communicable diseases is an example. But that's something that is kind of an OSHA philosophy that has been in place for a while. So that's really what the basis or the framework that was borrowed for this. There are some general requirements that employers have to provide a safe environment for their employees. And so while those aren't always spelled out in detail, There certainly are general federal requirements, and then of course on top of that, as industries are rolled out, there are fairly explicit requirements that the state is requiring.
Thank you. I have a series of questions. I'm just going to kind of run around the clock and pick on people indiscriminately. Jack, you're up first. Someone asked the status of your application to the government for the test you're working on.
So the test that we have, because we are not a CLIA certified laboratory, we cannot offer up our test by us to be approved by the FDA. So we would have to take our test and move it into a CLIA certified laboratory in order to get it approved for use. There are other laboratories that are putting in a very similar test to ours using the same technology to get them approved. But right now, what we've been doing as we try to seek solutions, because if we can't do it as a CLIA laboratory, to do that, we'd have to hire a laboratory director who's board certified. We'd have to go through a bunch of processes all to run one single test, which really is utilizing, there's a lot of red tape, and it's there for a reason. But in this particular case, in the state of emergency we're in now, we think that we should be able to offer up our competency in testing in order to get this approved. So what we're doing instead is we have human subjects based studies that we're running. We're offering up the test to examine spread within Grand Rapids currently, and we are utilizing that to push out our test. So we make sure that we tell them it's not a clinical diagnostic test, and we are offering it up for research purposes. In fact, we've talked to both Kent County Health Department and MDHHS, and if we find people who are positive, which we have, we are developing a relationship with them to make sure that they get the information so that contact tracing can occur. And one of the things that we are also trying to do with our test is to be able to offer it up not as a clinical diagnostic test, but we could offer it up to employers and allow them to utilize it as a screening test. And then if they have a positive hit, that can go also to the health departments for a follow-up screening. So we've been told that if we find anyone on any of our research protocols or otherwise, that can be done. So we're trying to figure out ways around the current restrictions on what we do. That's the best thing we can do right now. You're muted, Dennis.
Thank you. One other follow-up issue was based on your comment that can't find it, but seclusion has recommendations for seclusion have been set at 10 days. And the question was, wasn't it 14? Has it been reduced?
So there's two different issues right there. So if you've been exposed to someone, and probably our public health counterparts can talk about this better, 14 days is related to whether you think you've been exposed to someone, so you're self-isolating to determine whether you're developing symptoms or not. When we're talking about 10 days, we're talking about someone who has developed the disease and is conclusively known to have it, how long you are expected to be infectious, and how long you should isolate at a minimum. And so you should be staying isolated, and then for 72 hours after recovery or 10 days after the onset of symptoms, as what the CDC recommends.
Thank you. Nikki, a question for you came in terms of, is there an outreach mechanism for people you can't reach by phone?
Yes, and that's going to vary from community to community. So there are people finding softwares. I'm not super familiar with those, but I know in other communities throughout the state that's being used, and at the state level they're exploring that. There are some ways to identify some phone numbers. This is where having a really robust local public health department before a crisis hits is really important. So there are times where we've had to really dig deep into some of the networks of people we know of who we're looking for, but that has happened. What frequently will happen too is that if somebody is maybe not responding to a voicemail or something, there are some other ways that we can look for people using internet messaging apps, because not everybody has minutes on their cell phone or will respond to text messages. A lot of the clients that we already have on our caseload at the health department for various programs, Facebook Messenger is a really great way to find them. It's not HIPAA compliant. We do not share protected health information, but we could say, hey, somebody at the health department is trying to get a hold of you, call us, and we're able to do that. Is it perfect? No, but we do our best to try to hunt people down.
Well, thank you. We're getting close to the end of our allotted time, so I'm going to put one more question on the table and let anybody take a swing at it who wants to. And the question is, what can I tell my constituents about how best to avoid risk in an environment that is not risk-free? Short answers, please.
So I think it's wise to understand and assume that there is no risk-free environment. So that's really important. Really, the CDC and NIOSH have a great framework for this, but the biggest thing is distancing. If we keep in mind that it's person-to-person spread, it's those close contacts where you're within 6 feet of another person for more than a couple of minutes. That's where you have that risk. So anything you can do to introduce that risk or that distance plus face coverings is going to be really robust. If you can't do that distance, face coverings on both people is still can really help minimize it.
Dr. Verholden had to sign off, so Jack, Brian, you are the remaining panelists. Any thoughts you'd like to add on that, to that last question?
Well, I think it's really a matter of risk tolerance within the environment that you're allowed. So there are orders that allow some activities, and so I mean, once you understand what the risk is and how the disease spreads, and then you also know what the confines of the law or the current orders are, then you just have to. It's just a personal decision on how you operate inside of those. Hopefully, inside of those. So yeah, that's the. I don't think there is obviously there's no risk environment, but there are ways to mitigate those risks, and especially the more you know, you can see people really getting back into at least some activities with a fair degree of confidence that they can take much of that risk out of the equation for themselves.
Jack, you want the last word?
I think we're dealing with some of these issues on work reentry for our own faculty, staff, and students at MSU, and trying to figure out what's the best thing to do. And I think that we've talked about issues relating to their social. We've worked on all the things everyone's doing, right? Mapping out workplace spacing, social distancing, shifting, to try and make people feel better. I do think that offering up testing is going to provide psychologically some reassurance to people. I think that you can, and I even talked to you about this, Dennis, a little bit before we started, right? That people are worried about, what do you do about, you might want to take someone's temperature, ask them if they're healthy. That's not necessarily going to give people the peace of mind to come back to work. I just think that developing processes that make people feel confident that when they go back, regardless of whether it's social distancing, masks, or that their neighbors are being appropriately monitored, that you're going to get better compliance and people are going to feel better about returning to the places that they normally go to. So I'll leave it at that.
Well, thank you. We are very short on time. Before I turn it back over to Arnold, I wanted to thank our panelists. There's a lot of positive comments coming in on the Q&A screen. So I thank you all. I thank our legislative leadership for pointing us in this direction, and of course the Michigan Health Endowment Fund for their support for this project. Arnold, back to you.
Much like Dennis, I greatly appreciate the time and perspective, knowledge that all of our panelists have shared with us today. Thank you for taking time from your busy days. And thank you to our attendees as well. I hope that this was informative for you. My thanks to the Michigan Health Endowment Fund for their generous support. This session has been recorded and will be posted to our website, and we will send that link out to all of you that have attended, as well as make sure legislators in general are aware of it once it's published. So again, thank you very much to everyone, and stay well and be safe.